Good afternoon. This is Ethan Boger resuming our conversation about the PCRI conference held in LAX back in the beginning of September. We're continuing our review of the presentations. The one we want to talk about first is by Charles Snuffy Myers, the well-known oncologist who specializes in prostate cancer. And the topic of his conversation was durable remission, which is his big shtick. He talks about that a lot. Many of his patients are late stage prostate cancer patients, and so there's a lot of concern about how to manage that disease in its latter stages. So this is for men whose disease has progressed outside the prostate. So the big news is that Snuffy, as everybody calls him, is officially retired. It's now past November 1st, so that's it. He will continue to write and support Prostapedia, which is his monthly publication. PCIG, we get access to Prostapedia, and it would be very valuable for us all to click on that link and read what Snuffy has to say. It's not just Snuffy, he basically brings in experts in the field who write the articles for Prostapedia. Very well known web-based publication, which would be a great benefit to all of us. Okay, so Snuffy at last count had about 850 patients, and where should they go now that he's retired? So he recommended a certain number of doctors. These are all trained oncologists. Some of them are quite well known, like Charles Drake, who was at Memorial Sloan Kettering, if I remember correctly. William Berry, another well-known oncologist. Nick Vogelsang, Mark Schultz, obviously. Nancy Dawson, I'm not familiar with her. Oliver Sorter in New Orleans, and our own, and this is what kind of surprised me to hear this, but our very own Philip Lemming at Christ Hospital in Cincinnati is on Snuffy's recommended list. So that's actually great news for people here in Cincinnati who might be looking for an oncologist. So Philip Lemming and his team at Christ is highly recommended by Snuffy Myers. Okay, so Snuffy's big, his grand strategy, and I've heard this in the past, read this also on his website. He's a big fan of combination therapy. Okay, what's combination therapy? Well, that's where you attack the cancer with a number of drugs at the same time. His approach is to base the choice of drugs on liquid biopsy to monitor genetic changes that drive hormone resistance. So we all know that as cancer progresses, it tends to be for men who are on ADT, right? As the cancer progresses, it changes genetically and kind of evades, starts to become androgen independent. So he advocates liquid biopsy in order to monitor these genetic changes that drive that hormone independence. And what is liquid biopsy? That's where you take blood samples and you look for tumor DNA in blood samples. So this is also an emerging technology, which is very valuable for men who have tumor DNA in their blood. Not everybody does, but if you have metastatic disease, you're probably going to have some of that in your bloodstream. He gave examples of durable remission. And again, now my notes start to become a little bit more scattered because he was talking pretty fast and I didn't get everything, but here are a few bullets from his discussion. So he's a fan of intradermal estradiol to prevent this EMT. Well, what is EMT? Okay. As our disease progresses, the cells, the cancer cells, go through a transformation called epithelial mesenchymal transition. And that's where they tend to become more aggressive and more prone to metastasis. So he likes to use estradiol. Now, estradiol, I guess, is in the female hormone category. And so there's been some controversy about estradiol injections, but he likes them. So he uses estradiol in combination with metformin, statins, avodart, and a low glycemic index diet. So that's his basic approach. So estradiol, okay, metformin is a diabetes drug. It lowers blood glucose levels, but and that also has an impact on an indirect impact on cancer progression because it reduces the amount of insulin in the blood, and insulin is a growth factor for prostate cancer. So that's the indirect impact. The direct impact is that it activates APK, which is a gene that is tumor protective. So that's metformin. He gives metformin to pretty much everybody, as far as I know. And now statins. Okay, so statins, what? Reduce cholesterol, right? So studies have shown that men who are on statins tend to have less prostate cancer. So he likes statins as well. And then dutasteride, which is avodart, that we know inhibits dihydrotestosterone, which is kind of turbocharges the impact of testosterone in prostate cancer growth. So he likes avodart, and he puts a lot of people on avodart. I think if we go to any of our prostate cancer conferences, or maybe half the men are on avodart. Okay, and the last piece of the puzzle is a low glycemic index diet, the so-called Mediterranean diet. He's a big fan of that. And again, the point of that is to reduce the amount of insulin that's secreted in the blood, right? Low glycemic index meaning that what we eat gets converted very slowly to sugars in the blood, and therefore there's less need for insulin. Okay. The other pieces of his puzzle are to avoid corn and other food high in omega-6. So what is omega-6? Okay, he's also big on this whole subject of the omega-3 versus omega-6 ratio in our bodies. Studies have shown that primitive man had relatively high ratio of omega-3 to omega-6, while we in modern Western society, that ratio is extremely low, and that is not good. Omega-3 is cancer protective. Omega-6 promotes inflammation, and inflammation in turn has been somehow linked to prostate cancer. Although that's also been refuted. But anyway, so there's a lot of studies. This is big right now. You can go to the drugstore, and on the shelf you'll see 24 different omega-3 capsules on the shelf. It's really becoming popular. Okay. But omega-6, yeah, you want to minimize that. So no peanuts, other foods that are high in omega-6. Okay. The next big piece of his puzzle is the importance of slowing PSA doubling time. Now, why is that? Well, if you do the math, okay, if you can reduce the PSA doubling time by half, you may add years to your life, just due to the fact that your prostate cancer is going to grow even more slowly than it usually does. So it's really a long battle. Men can survive for years, even with stage 4 disease. And a lot depends on how you fight that battle. Okay. So here's the next piece of the puzzle. Okay. So let's say you do all that stuff and your PSA stabilizes. All right. So it doesn't grow. It's not going up anymore, but it hasn't dropped, but it's not going anywhere. So you really reduced your PSA doubling time. The next step is to stop Avogadro. When that happens, your PSA is going to rise again. So if your PSA was between 0 and 1, and you've done a great job in stabilizing, okay, he says, okay, let go of the Avogadro, let the PSA rise. Why? Because we've discussed earlier in this discussion that the new imaging tools, the PET scans with radio tracers, can reliably detect metastatic disease when your PSA goes above 1, and if it's even better if it's above 2. Okay, so that's the whole point. So he says, don't just blindly go after the disease, try to locate it. Okay, and if you do find it, if you have very limited number of metastases, you can find them and knock them out with radiation therapy. We also have heard from other people that you can even knock them out with cryo if they're accessible to cryo. Okay, so there you go. There's Snuffy being serenaded. You know, they made a big deal about him because he's been a big supporter of PCRI, and he's collaborated with Dr. Schultz for many years. You know, he's kind of the rock star of the prostate cancer world, and so they made a big deal about his retirement. Okay, so again, now the following are some of my snapshots from his presentation. I didn't catch everything, and I'm not sure I can explain everything, but here's my take on some of these slides. So he talks about the traditional approach to successful combination therapy. So so he talks about when you have when you use multiple agents, right? Like maybe you're taking ADT and you're on Dexatel, or you're on some of these other medications, right? So uh, you reduce the amount of toxicities. Well, I'm not quite sure why, and this is actually a rather important slide, which I didn't quite understand, but it would be, for those of us who are curious about it, it would be interesting to look more into what he's talking about here. But he does talk about uh, using combination therapy, uh, monitoring for drug interactions, uh, and he says these principles apply to every kind of disease where there's resistance to treatment, which is in cancer, AIDS, and tuberculosis. So it's a general oncological strategy. And here's where he talks about lengthening the doubling time, and here's the progression of the disease, um, and so you can read this later. I don't want to get too much into it, but it's basically about you're going from left to right here. I think the graph is PSA, and you know, so when you've been newly diagnosed, your PSA has been rising, then you get treatment. The PSA goes down to 0 if you like prostatectomy, and it stays very, very low for a long, long time. Then it starts to rise. Then you knock it down with some kind of treatment, and it goes on, and then rises again. You knock it down and treat it again. So, so what he's trying to say is this battle can go on for years and years and years. In other words, his whole approach is that prostate cancer, even if it's come back, is not a death sentence, that it's possible to battle it for a long, long time with reasonable quality of life. So here are some of his combination treatment strategies. Strategy number 1 is a combination combine agents with the treatment class, like hormonal therapy, which is LHRH agonists like Lupron, plus Xtandi or Zytiga, or Xtandi and Zytiga. And then, of course, there's the cytotoxic chemotherapy, which is Geftana, carboplatin, And then there's the new classes of drugs, the immunotherapy drugs, which is CTLA-4 plus PD-1L. These are immune inhibition of immune suppressors cells. So it kind of prevents the immune system from regulating itself. It revs up the immune system. Leukine is another kind of drug that I'm not that familiar with, but uses it in combination with CTLA-4. And of course, there's vaccines and checkpoint inhibitors that would be Crossback, which unfortunately has not been proven to be that successful so far. Okay, another treatment strategy is combining radiation with hormonal therapy or hormonal plus cytotoxic chemotherapy, which would be Lupron plus Taxotere, right, docetaxel, hormonal therapy plus immunotherapy, all these different combinations. So, he he talks about all these different strategies, and this is where a good oncologist with good experience with prostate cancer can be a very valuable provider, for people who have recurrent disease. And again, there are not that many prostate cancer oncologists, and we're lucky to have Dr. Lemming here in Cincinnati. So he apparently knows about all these strategies and would be a good person to go talk to. And then he gave an example of a person, MH, the initials of this person, who was diagnosed in 2005, and then, he went through all these stages, and so, rather than going through all this, I'll just say that, he had remission, then it came back, he had remission, and then he, like he says at the very bottom, the remission maintenance is Avodart and Celebrex. Celebrex is what? A COX-2 inhibitor. This is one of the genetic pathways that we want to inhibit. It's well known. You can use you can use aspirin as well, but I think the problem is maybe Celebrex is more potent than aspirin. I'm not sure about that. You can talk to Dr. Lemming about it. Okay. This is a slide about statins. Now, Snuffy is very fond of statins. From what I've heard, statins also have significant side effects. So, buyer beware. But, if you have metastatic prostate cancer, you want to use all the tools in the toolbox, and statins is one of them. So this is a comparison of a bunch of studies that were done on prostate cancer specific mortality, so people who have died of prostate cancer. And he wants to show here that people who are on statins live longer. That's in a nutshell. Okay. And Avodart, which is again one of his favorites. So, the big takeaway here is that 2 years there was a more than 50% reduction in metastatic disease requiring hormonal therapy for men who were on dutasteride. And again, the side effects of Avodart are not very great. That's why Snuffy really loves it. Okay. Then he talked about treatment of PSA only recurrence. So this is where, you've got, you had a prostatectomy, say, then, later, for some reason, PSA started to rise, and then, you monitor your PSA, and the doubling time is suddenly starting to go shrink. Anything below 12 months is considered that you really need to see what's going on. And then, so for that kind of patient, he would put them on this regimen of diet, exercise, Avodart, Metformin, statin, and he says this may completely stop the PSA rise. Exercise is something that was not Well, it was actually rather, it was actually talked about quite a bit at the conference. Not so much by Snuffy, but like Dr. Moyad talked about it a lot. You know, he's the director of an integrative medicine clinic up at the University of Michigan, and he discussed how exercise is extremely important in managing prostate cancer. Why? Because when you exercise, you increase muscle growth, you reduce fat in your body, especially the the bad visceral fat. This reduces insulin levels. Um, this reduces estrogen levels. It makes you a healthier person and also has a direct impact on prostate cancer. And I would say there's been a lot of studies, though that retrospective studies that show that exercise can significantly slow disease progression. Anyway, so then uh, yeah, at the same time, on this particular regimen, it also dramatically improves cardiovascular health. Well, yeah, because you're reducing blood glucose level, you're reducing cholesterol, and you're reducing weight. You know, your body gets healthier, so you're improving outcomes for your heart as well. And then he talks about options for continuing this regimen after uh, the, uh, um, once your PSA has started to go up again, and talks about stopping Avodart and then doing the detection with PET scan. Uh, uh, and he talks a little bit about the risks of his program, including the side effects of radiation, the Avodart impact on sexual function, and of course, occult cancer progression. So if you have slowly rising PSA, you may not be able to detect where your cancer is, and that's what we call occult cancer progression. So that was it for Snuffy. It was a very interesting discussion, and I'm sure the prostate cancer world is sad to see him. Of course, he's not completely done. He still publishes his magazine. All right, the next, so actually that was the end of the formal sessions, and then um, they had a bunch of sessions on Sunday run by a bunch of different experts, and um, these were less formal sessions held in smaller um, halls, and unfortunately they overlapped. So there were 4 or 5 of them going on at the same time. I wanted to, but couldn't be in 2 places at once. So I had to pick and choose. I did want to hear about immune therapy because I missed the other big lecture on it, and so I caught the one by Dr. Richard Lamb. He is an associate of Schultz, and I believe he's at UCLA also. So he's quite well known in the uh, prostate cancer oncological world, and he talked about immune therapy. So, you know, I think this is not, I don't think what he had to say was um, that new. I think many of us have heard about some of these issues, but he kind of rounded them all up. So uh, he basically said that in general, the challenge of immune therapy is to educate the immune system to find the cancer, then to overcome the so-called force field surrounding the cell. What is this force field? Well, these cancer cells are, in a way, incredibly intelligent because they tend to also communicate with the adjoining cells, adjoining tissues, and kind of tell them. It's almost like a occupying army telling the civilian populations what to do, kind of like mobilizing the civilian population to not allow the immune system to attack the cancer. So it's kind of like creating a shield around the cancers. And so that is a big problem because if the immune system can't detect the cancer, they will not attack it. And that's what's been going on in the cancer immunology world, is figuring out how to get through this force field and attack the cancer with the immune system. So one of the big cheeses has been Crossback. Crossback is basically a kind of combination therapy that's been around for at least, I want to say, about 7 years. And it finally got into phase 3 clinical trial. And at the time of the PCRI conference, um, the the results of the phase 3 clinical trial the results were to be announced shortly after the conference. So at the time, that was the news. And as he said, it could be a headliner. Um, so what is Prosvac? It's a combination of immune checkpoint inhibitors, pembrolizumab, which is Keytruda, and nivolumab, which is a PD-1 inhibitor. Okay, these are two um, commercially available drugs that are used now for combating all kinds of cancers, not just prostate cancer. In fact, mostly not prostate cancer. So anyway, so Prosvac uses these immune checkpoint inhibitors together with a genetically modified vaccine, which is supposed to infiltrate into the prostate cancer cells and make them more vulnerable to the immune system, which has been revved up with these checkpoint inhibitors. So this trial was the trial was only for men with castration-resistant prostate cancer, CRPC. And why is that? Because when you give people these immune checkpoint inhibitors, you are making them vulnerable for autoimmune disease side effects on the well cells in your body from the over-revved immune system. And these side effects can be very, very serious, including death. So if you're castration resistant, if you're on your last legs and you're willing to take the risk, you go on this clinical trial hoping that will extend your life. Um, so for these men, the benefits outweigh the risks. For men who are still hormone sensitive, there's ADT, which we know has its own side effects, but they're not lethal by and large. And so that's why this trial was only on men who were at CRPC. So I can just add that the Prospect results did come in shortly after the conference, and it was a big letdown because the FDA stopped the trial because they could not see any significant benefit after almost 5 years, I believe. Uh, the men on Crossback did not outlive the men in the control group, who, by the way, might have been on other drugs. So they stopped the clinical trial. This was a big letdown. And then there's a reason why we think this was not entirely surprising. And I don't want to get into that right now, but you can read about it. If you Google Crossback, you'll see there was something about the phase 2 trial which was kind of interesting. Okay, so he talked about Crossback, then he talked about cryo plus PD-1. And what is that? So there is a doctor in Florida named Gary Onik, O-N-I-K, who a few years ago created a protocol for doing cryotherapy on the primary tumor in the prostate, and then injecting the body with PD-1, which is one of the immune checkpoint inhibitors. So the idea being that the cryo, which is the freezing of the prostate, I guess the prostate, or and if it's done focally, the prostate cancer, will actually allow enough of the prostate cancer tissue to be ejected into the bloodstream and will be recognized now that it's been liberated from its force field, okay, can be attacked by the immune system, which again has been revved up with this immune checkpoint inhibitor. So this was that was Gary Onix's protocol, and that's being more widely recognized now in the prostate oncology world. I have a couple of internet friends who have done this, by the way, and after a couple of years, I have heard about mixed results, that it works for a while, but not forever. So I don't know. You can also read all about it on the internet. Okay, he talked about the Guardant 360 liquid biopsy, and this is the liquid biopsy test that Snuffy uses, called Guardant 360. And what he was saying is what I mentioned earlier, that it won't work if you don't have tumor DNA floating around in your bloodstream. So, and that only happens when you have metastatic disease, essentially. He talked about PARP inhibitors. Okay, so what are PARP inhibitors? So, I think PARP, the commercial name is ipilimumab, right, for the PARP inhibitor. So this was used for breast cancer and has been quite effective. Well, because in breast cancer, a lot of women have the BCRA mutation. So when they gave this PARP inhibitor to men with prostate cancer, they noticed that some men had remarkable remission, but many other men had no response at all. And they found out that, yes, those men that had the BCRA mutation, those were the guys who responded well to PARP inhibitors. But that's only about 10 to 15% of men. It's not that common in men. So, by the same token, if you didn't have the BCRA mutation, maybe you wouldn't have the prostate cancer to begin with. So, it's not a good thing to have, but luckily there's now a drug that can help with that situation. Here is a few slides. There's Dr. Lamb. Basically, he was discussing some of these mechanisms for how to attack the cancer with immunotherapy. And this is actually a slide from Dr. Nordquist's, and I think he actually copied Dr. Nordquist's, and he actually misspelled his name up here. He actually copied the same slide that I showed you earlier. Okay, I would like to talk for a few minutes about the next presentation because I thought it would be quite interesting and informative for many, many people who might want to take advantage of the new prostate, the new prostate cancer imaging technology. So this was a presentation by Dr. Fabio Almeida, who runs, I guess, the Phoenix Molecular Imaging Center that is in Phoenix, Arizona. Okay, so he talked about PET-CT imaging and prostate MRI imaging. Well, he didn't say very much about MRI. In fact, I think we probably heard more about MRI than Dr. Almeida from his discussion. Didn't tell me much that we don't already know. Those of us who listened to Dr. Barkin and Dr. Bush, who presented it at PCRI in the recent past. But he did have something to say that in response to a question I asked him. Okay, so what I've read, well, not read so much, read, but also heard from, especially from Dr. Bush in Chattanooga, is that a very accurate technology for looking for metastatic disease is something called whole body diffusion. So you sit in the MRI machine, and the MRI machine scans your entire body with diffusion-weighted imaging, which is one of the technologies used to enhance the accuracy of MRI. But he says it's so I asked Dr. Almeida about this, And he said it's a non-starter just mostly because of the cost, because it's 3 hours in the machine. It's not only the 3 hours in the machine, but also the toll on the radiologist, because the amount of scans. Uh, uh, he also talked about, in other words, it's very costly, not just about machine time, but also about radiologist time. So it's a great tool, but not a practical one, in his opinion. He also talks about side effects on patients who sit in the 3 hours in the machine, like audio trauma. So audio trauma, if you've ever been in a 3 Tesla MRI machine, the thing is very loud, and it's been my complaint, and I don't know why it hasn't been addressed more by doctors. Well, it's because radiologists are not audiologists. They don't care about your ears. They only care about detecting your prostate cancer. Okay. But Dr. Almeida did agree that it's an extremely sensitive and precise diagnostic tool. So maybe sometime in the future it will become more affordable and more widely used. Okay. But what does he do? Okay. So his typical process, this is the second bullet here, is his typical process when you present with rising PSA, right? Okay, so let's say you've had prostatectomy, but your PSA is rising now, and you don't know what the hell is going on. So the first thing to do is to give you an 18F bone scan. And again, I think we discussed this a little earlier. 18F is an extremely sensitive scan for metastases that may be in the bone. Okay, specifically in the bone. Okay, and it has, like he says, 1 millimeter resolution. That's pretty small. Okay. And if you have a 1 millimeter metastasis in your bone, you probably don't even feel it. It's not presenting as pain, but it's presenting because your PSA is rising. Okay. So 18F could be a very valuable tool for that. And then his tool is C11 acetate. Okay. So what is C11 acetate? So C11 again is the radioisotope, and they attach it to an acetate, which is a short chain fatty acid, which cancer cells, especially prostate cancer cells, are very avid for. They're growing relatively quickly, and they need fuel. Well, they use choline and acetate as a fuel, and so they consume it more than surrounding tissue, and they can be detected. And he says the advantage of C11 acetate is it's highly sensitive, especially for the pelvic area. So if you have slowly rising PSA after prostatectomy, so the concern is there may be some cancer lingering in the pelvic bed, or maybe in the surrounding lymph nodes, the nearby lymph nodes. So C11 acetate, he says, is extremely accurate for that. So if that's your situation, you may think carefully about going to Phoenix Molecular Imaging for this scan. And I think Dr. Almeida is widely recognized in the field as a really excellent radiologist. I would think hard about going there. It would be, I think, probably a pretty good way to go if that's your situation. Now, he talked about Axumin, okay, and this is where all these experts conflict with each other, right? Because they're each pushing their own technology, and he says that C11 acetate is much better than Axumin, and this is what naturally what he's going to say because he uses C11 acetate. Of course, we know the problem with C11 is that its half-time is very short, and therefore it's not a cheap test. Also, not covered by insurance. So there is like a $3,000 fee to have this test done. If you can show a financial burden, he does have a foundation that provides stipends based on need. Now, he did say something rather interesting. Okay, when you get these scans, whether it's C11 or 18F or 68 gallium, you're going to be subjected to a dose of radiation. Not only that, the PET scan is overlaid over a CAT scan, right? That's why it's called PET CT. The PET scan is kind of very, it's hard to say, well, okay, you can see the cancer, but you can't tell exactly where it is. So what? They overlay it over a CAT scan, and then they can tell you exactly where the lesions are. But then you're getting a double dose of radiation, one from the radioisotope and one from the CAT scan. So he says that now there is a new CT technology called contouring that adjusts dosage to area being scanned. So the total dose is really only a small fraction of what it used to be. It's I think, really an order of magnitude less than traditional CAT scans. So anybody who's going to go for a CAT scan should ask the radiologist, is your CAT scanner the new contouring type that has the contouring technology? We should all ask about that, because if we don't ask, they're never going to get it. Okay. And they talked about 68 gallium, PSMA, and the fact that there are many types of ligand. That's the antibody that looks for the PSMA, right? There are many, many of these ligands out there. Everybody's experimenting with them now. And the big question is, which one will win out? So that's kind of interesting. So he talked about these ligands. So the choice of ligand is limited to small molecules. And the reason for that is you want to reduce the chance of allergic reactions. And he talked about two of them that could be theranostic agents. And we know that theranostics is the combination of therapy and diagnostics, and that's what 68 gallium is. So when you have these ligands that can carry either 68 gallium, which is a very low radiation dose, which is a diagnostic dose, right? Not supposed to harm the body. And then you can attach the lutetium-177 or actinium-225, which carry a therapeutic dose, which is supposed to, go right to the cancer cells. So that's what theranostics is. And anyway, so he says the problem with 68 gallium is the bladder uptake shrouds the pelvis. And I think I mentioned that earlier in the presentation. That's a problem with 68 gallium. So if you're going to get a 68 gallium scan, make sure you enter your bladder. I'm sure it will tell you that. Okay. So then he talked about PSMA. It's actually a misnomer. Actually, it's not just present. So it's PSMA stands for prostate-specific membrane antigen. So it's an antigen that presents on the membrane, right, the outer surface of the cell. Well, it's a misnomer because it's not just presented in the prostate cells, in the prostate cancer cells, I suppose. And that is a problem because when you get the lutetium-177, okay, it can actually attack some of the cells in our body that also present PSMA, like, for example, our saliva cells. And there may be other, I guess these are epithelial cells, right? These are the cells that surround ducts in the body, like the saliva ducts. And so that can be an issue. And again, these are some of the devil's in the details, they say. So we hear all the hype about theranostics. Then we hear, oh, by the way, there can be these significant side effects. Okay. Anyway, he talked about the predictive value of these scans. And again, this has been mentioned again many times. It's highly PSA related. If the PSA is 0 to 1. Oh, and this was rather interesting. So he says if the PSA is between 0 and 1, which is kind of low, the sensitivity is a function of doubling time. So if your doubling time is very short, in other words, that the PSA is rising rapidly, So in spite of the fact that it's between 0 and 1, if it's rising rapidly, it might be easier to detect. Okay, then he talked about Axumin, again, we kind of talked about why he doesn't think it's so great. And you can read the slide. He's got some information about it. And then, of course, this is why he really likes C11 acetate. He says the overall detection rate is 88%. I think he may say that. I think other studies have shown it's not as high as that. But again, all these studies have been done with a relatively small number of groups, although he says that he's looked at over 1,400 patients and he's got an overall detection rate of 88%. That is quite remarkable, and I have not seen it in other studies. But, he may be, a lot depends, I think, maybe on how good the radiologist is who's reading the scan. And if he's a really good radiologist, has trained his radiologist team well, maybe they get better results. And that's a really good reason to go to Phoenix for the scan. Yeah, he talks about the PSA and doubling time influence on detection. We just talked about that. And here's some slides showing some of the results of the scans. Here's a slide talking about the different ligands, and we talked about that. And that is the end. These are the two big shots, Moyad and Schultz, on the very last day, wrapping up the conference. I would say my overall impression of the conference is that there were some really excellent presentations. Maybe not that much new stuff that we couldn't read from doing all the looking through Google for a year, but having everybody in the room was very exciting. There were also a bunch of booths run by different organizations. For example, Space Ore had a booth. Axiom had a booth. There were a lot of booths by different organizations. So it's a booth by Life Extension, which is a big provider of supplements specifically for prostate cancer. And it was also an opportunity to meet a lot of people and network and schmooze. And so it was, I think, a great thing to do, maybe at least once in a lifetime, to go there and see what it's all about. So I would encourage anybody. It costs $60 to sign up for the conference, and really, you can stay at the hotel, never venture out. I never even rented a car when I was in LA. There was a shuttle taking me from the airport to the hotel, which was a 5-minute shuttle ride, and never left the hotel during the presentations. Everything was right there, and it was great. So I had a good experience and would encourage everybody to think about going. Thank you very much. If you have any questions, I would refer you again to the opening slide that has my name and phone number. If you have any questions, I'll be happy to, you can address them to that email, and I'll be happy to discuss them with you.